cancers, or the cancers that I treat, one of the biggest risk factors is obesity. So obesity is one thing. And then, of course, the more generic things like smoking. Smoking is quite a big one. Vaping in particular. So these are particular risk factors for cervix cancers. HPV is spread by sexual contact, but it's not a sexually transmitted infection. So 80% of people who are having sexual intercourse will have been exposed to H. The really good one, exactly, that people, often die with it, but of something else. And it's just there, but it's just stable. So you find a lot of people are living with cancer, but it's not automatically a death sentence these days.
Is the leading cause of death in the UK, and 1 in 2 people will be affected or diagnosed with cancer in their lifetime, and over 375,000 people are diagnosed with cancer every year in the UK, which is about 1,000 a day. But the good news is, in the past 10 years, the survival rate has doubled, with people having to live more than 10 years after being diagnosed with cancer. And today I've got somebody in the studio, an expert in cancer, who's going to give us an insight into how this could be survived, how we could prevent it. We are happy to have you in the studio with us.
Thank you.
And can you just introduce yourself to our viewers?
Yeah, so I'm Dr. Stacy Brian. I'm a consultant gynecologist and gynecological cancer surgeon. So essentially that means I'm a women's cancer surgeon. I treat women's cancers.
Good. So what inspired you into getting into medicine and oncology as well?
Yeah, it might be a bit of a long story, so bear with me here. Bear with me here. So what inspired me to get into medicine? So initially, when I was a child, I went to my GP for small, ailments here and there, and I just really loved her manner. She listened, I didn't ever feel scared. I know as a child going to a doctor can seem quite scary, but I didn't ever feel scared going to see her. Mm-hmm. She always listened. Her manner was very soft. She was, and I associated going to see her with feeling better. And then that made me feel like I want to do this. So this was from the age of maybe 6 or 7. I think my mum tells me that I turned around and said to her, I want to be a doctor. I want to do what this doctor does. She's like, are you sure you don't want to be a teacher or anything like that?
Is that in the UK?
It's in the UK. Okay. This is here in the UK. So I'm like, are you sure? The teacher, maybe you want to teach? I say, no, I want to be a doctor. Teacher? She's not.
So
she's not interesting. I know.
I
think she just thought, such a young age. Yeah, whatever. You don't really know that. But yeah, since then, I actually stuck completely with it. Through sort of secondary school, and again, all my schooling, everything was here. Through secondary school, I met like-minded people as well, thankfully. So there are about 3 or 4 of us that went on to then study medicine.
From the high school here in the UK, you guys are talking about what you're going to be in the future.
Exactly.
So you're not talking about which parties or clubs you're going to go.
Exactly.
I'm not saying, I don't have anything against parties or clubs. I'm just saying at that age,
I know you wouldn't be thinking about that. Exactly. So I was lucky in that I had, like I said, that group of people that were similarly minded. And then, so I got into sort of medical school, went through the training. At that time, because I was inspired by my GP, I thought I'd want to be a GP. But then I did my GP rotation and thought, I'm kind of limited by what I can do. You can see certain things and prescribe this, go away, come back. But actually, that's all you're limited to do. You then have to refer on. Mm-hmm. So I thought, no, I want to do hospital medicine. And then I'm thinking maybe pediatrics, so with children, because they're funny, they're resilient, even though they're unwell, they bounce back really quickly. Then I did the pediatric placements, and obviously it wasn't as all happy as that. I saw children with like leukemia, all these sorts of things, the struggles with the family. Particularly with leukemia, you have to be very careful about your child getting infections and things, and sometimes the family couldn't go in if they're going through a particular crisis at that point in time. So that was a bit hard and difficult to handle. So I thought maybe not for me. And then I did my obstetrics gynecology placement. So this is the care of women during pregnancy, during their delivery, after that as well as all women's problems. And I thought, yeah, this is what I want to do because there's so much variety. And then eventually I found my way into doing gynae-oncology. So I spent some time in theatres doing operating. And actually it was a surgeon who said to me, oh, you've got a surgical hand. Do you think about going into oncology?
Ben Cassin, yeah.
Right. So I thought, I hadn't thought about it, but okay, why not? And then she happened to get me a fellowship for a year at the Royal Marsden Hospital, which is a cancer centre. And there, I've developed my skills and I thought, yeah, this is what I want to do. So that's how I've kind of found my way into oncology and where I am now.
So a lot of inspirations along the way.
Absolutely.
So from your GP,
absolutely,
who inspired you, and your sponsor who let you into the fellowship as well.
Yes.
So how will you describe this journey? Because there'll be a lot of people listening, and you've probably rotated in every department possible. So how did you see this journey, and what will you say to people who are looking to do something similar?
Yeah, no, sure. There were a lot of ups and downs. I probably don't. I mean, my journey is probably a whole podcast in itself.
Okay.
So I won't go through everything, but there were a lot of ups and downs. There were a lot of closed doors that I had to kind of navigate around. And I always say, whenever I'm speaking to younger people who want to get into medicine, that a closed door or no is not necessarily no. It's maybe just not now, or think about another route, basically. Because there's certainly loads of obstacles and hurdles that I came up, and I just found different ways to kind of get there. So as long as you know that this is your goal, this is what you want to do, just find different routes to getting there is what I would say. But there were a lot of ups and downs, but I learnt so much. I think the importance of mentors as well, having mentors, having people around you that are really pushing for you, grabbing opportunities, sometimes not always saying no to things and being scared, the imposter syndrome and being scared to jump into something. We'll be like, not quite sure. Just be confident to say yes. I now have the problem of not being able to say no.
Okay.
But just having the confidence to go into something that's new. You don't know what doors can open, basically. So it's been an interesting journey, but a very, very rewarding one, I should say.
Good. Fantastic. So what does your typical day, what does it look like?
When it looks like, it's probably easier to describe my typical week.
Okay, the typical week.
Because it's just so varied, basically. So I'll describe my week coming up, for example. So on a Monday morning, we usually have our joint oncology clinic. So this is where we see patients who've been diagnosed with cancer. So I must add, I currently work at what we call a tertiary unit. So it's a special unit where everyone across the country or within our catchment areas are referred in for specialised care. So I'm, as I said, a surgeon. We work alongside our medical oncologists, so they deal with the chemotherapy, our radiation oncologists or clinical oncologists that do radiotherapy. And also, multiple other people. But in our clinic, it's that kind of multidisciplinary type team. So patients who've been diagnosed with cancers, who we see, we talk, we go through treatment, surgeries, etc. with them. So that's usually on a Monday morning. Then we have a mini meeting where we discuss all the patients on the ward, all the operations we did the week before, any complications, any issues, and, making sure that the patients are all well. Then every other Monday afternoon, I do a colposcopy clinic. So this is where women who've come for their cervical smear, cervical screening, who may have had an abnormal smear test, need to have a closer look at the cervix. So that's what that clinic is, where I'll have a closer look. And if I need to take a biopsy, so a pinch of tissue to check that, everything is okay, then that's what I do for that clinic. And on Tuesday, I don't tend to work clinically within the NHS, but I do have other roles within my job. So I'm what they call the college tutor, which is basically looking after the well-being and welfare of the trainees within our department. So I do, take that time to do anything surrounding that. I also have a little bit of a role in risk management. So where there's issues that may not have gone as it should do within the hospital, investigating those sorts of things. So I do that. And I tend to do a lot of that work on the Tuesday. On a Wednesday, I have a rapid access clinic. So this is known as what they call the 2-week wait. So those patients who go to the GP with cancer symptoms, who need quick investigations within the 2 weeks, they get referred into this type of clinic. And there I will, speak to the patient, take a history, find out what the symptoms are, and I can do a scan at the same time. And also if I need to take any biopsies, etc., I will do that. And then we'll see the patient again with all of the results. And then an alternate Wednesday afternoon, I will do a specialised vulval cancer clinic. Thursday, I have an all-day operating list. Friday morning is an operating list. And then Friday afternoon is our big multidisciplinary team meeting. So very varied.
For our viewers, in case you're wondering, when you go to the hospital, you can't see doctors.
Exactly.
It's not like they're not doing anything. They're so busy. That
Yeah.
is busy.
Yes.
How do you cope with, how do you balance this with your personal life?
It's difficult. It's very difficult. I'm not going to sit here and say, oh, yeah, I do this as easy. I think you have to, number one, have boundaries. Number two, as I was saying about learning now to say no to certain things. Obviously, as I said, there are certain opportunities you just need to be like, have discernment basically as to what you say yes to. It's difficult. It's tiring. But not every week is the same. You know, I may not have a particular clinic one week, so I've got a little bit of time. There may not be, you know, as heavy a clinic. So it's difficult. It is a difficult balance to achieve.
Okay, thank you. So let's go to the main topic for today, which is cancer.
Yeah.
What are the leading causes of cancer these days or in the UK?
Yeah. So it's a difficult one to unpack because there's so many different types of cancers, all right? So if I speak on gynecology, so women's cancers in particular, so there are 5 types of women's cancers. So womb cancer, cervix cancer, ovarian cancer, vulva and vagina, basically. Okay. And what we find in particularly with womb cancer, a lot of this is about diet, lifestyle, you know, how we live.
Sorry, wait. The 5 you described,
yes,
they're more gynecological cancer,
yes,
kind of not breast, because I know there's still...
Yes, no, it's the right thing to say. So in Europe, for example, gynecologists will treat breast cancer in Europe, in some places in Europe. Here in the UK, we don't tend to. It tends to be the separate breast team that deal with breast cancers. Okay. So thank you for clarifying that as well. So when we look at our cancers or the cancers that I treat, one of the biggest risk factors is obesity, and this is because fat tissue produces or kind of converts a lot of estrogen. Estrogen is a female hormone which can affect the womb and the lining of the womb. And if you have too much of this, it causes thickness of the lining of the womb. And therefore, this puts you prone to developing cancers of the lining of the womb. So obesity is one thing. And then, of course, the more generic things like smoking. Smoking is quite a big one. Vaping in particular. So these are particular risk factors for cervix cancers. For cervix cancer, there's something called HPV, human papillomavirus, and there's been a big drive about vaccinations to try and reduce the risk of HPV. But HPV is a big leading factor, as well as smoking for cervix cancers, for example.
How do people spread HPV?
This is an interesting topic. So HPV is spread by sexual contact, but it's not a sexually transmitted infection, the way that you will think of. I know sometimes it's very difficult when I'm trying to counsel my women to kind of get your head around that. So 80% of people who are having sexual intercourse will have been exposed to HPV in their lifetime at some point. It has no symptoms, and most of the time it doesn't cause any issues. HPV is cleared by the body so long as, like I said, you don't smoke, because smokers have a difficult time in getting rid of this HPV. So hence why, the risk factor is there. So it's not a sexually transmitted infection the way that you would think of gonorrhea, chlamydia, all these sorts of things that need to be treated. And if they're not, then they cause consequences, etc. later down the line. It's not in that way, but we know it's by sexual contact that this thing can spread. And as I said, we don't know about it because there's no symptoms per se. We only detect it on the cervical smear test, on the screening. And if we detect it, then like I said, patients are referred to colposcopy clinics so that we can have a closer look and just make sure that this HPV is not causing changes to the cervix. Yeah. So a lot of people can just have it and it's not causing problems. So
if somebody comes to your clinic and you find out that they've got HPV in their cervix, if I'm saying it right.
Yes, yeah.
Does it have a threshold where you get concerned?
So yes, so it's interesting. So like I said, the majority of people will clear their HPV. For those who don't, it tends to hang around and it starts to cause changes on the cervix, which is the opening or the neck of the womb. All right. And the changes that can occur are in sort of 4 different stages. All right. And they go from kind of what we call borderline to what we call high grade changes. And even that is pre-cancerous changes. It's not cancer. But it's changes that we have a look at, and if we think needs treatment, so, taking a biopsy or taking away those abnormal cells, then that in itself will prevent cancer from developing. So yes, there are different levels before you even get to it causing a cancer.
So you've talked to us about obesity, which is mostly diet.
Yes.
And then you've spoken about smoking and vaping.
Yeah.
And then HPV.
Yes.
What about genetics? What role does that play?
Yeah, no. So majority of the time, again, dealing with female cancers, majority of the time they are what we call sporadic. So it's something that happens in the cells start to grow uncontrollably and a cancer is formed. But you're right, there are certain cancers that can be linked to genetics. So again, for gynecological cancers, the most common ones, or the ones that you may have heard of, are the BRCA gene mutation, or BRCA, and there's 1 and 2, is most commonly found with breast cancers. So people are tested when they have breast cancer to see if they have this particular gene. And then, of course, it has implications for the children, the female children, etc. in the family. They may need to be tested, etc. Now, we also found that this BRCA gene is involved in the development of cancers of the ovaries. So again, these are the sorts of things, if people found to have BRCA genes, if there's certain ethnicities, etc., that they will be tested for this, and just to see if it's more so for the treatments now we can tailor towards those who have the gene and those who don't. Another one is called Lynch syndrome. So this is a syndrome which is again, it's more found in those with cancers of the bowel. But we also know that it can be linked to cancer of the womb as well, and some ovary cancers. So those are the two main kind of genetic ones that we need to keep an eye on patients if they're found to have these genes.
So for our viewers out there, what are the common signs and symptoms of cancer that they should be looking out for? And the reason I'm asking this is you read on Daily Mail, not advert to Daily Mail, but where people said, I've visited my GP many times. I've been complaining about abdominal pain, and then they just keep fobbing me off with paracetamol, all of the stuff. And then they went to the hospital because it got worse. And next thing, they're on stage 3 or stage 4 terminal cancer. So what are the signs and symptoms? And why is it so hard to diagnose this?
Yeah, no, absolutely. So again, they're different for the different cancer types, but broadly speaking, it will be bleeding. So irregular vaginal bleeding. So if someone's having bleeding outside of their normal menstrual cycle that they think is not normal for them, it's always best to have that checked. For women who have gone through the menopause, so they've had 1 year of no periods at all, if they suddenly start to bleed, that's a red flag symptom that we advise they need to come in, so they would see someone like myself in what we call the rapid access clinic. And those are the earlier signs of cancer of the womb. Again, the cells within the womb are dividing uncontrollably and it causes bleeding. So that's one of the very first signs, all right? When we move on, and similarly with vulval cancers, vaginal cancers, which are much rarer, but you may start to get some itching in the vagina, in the vulva, and you may see some lump on the vulva and ulcer on the vulva. Again, these are things that prompt that you should go and see your GP just to have it checked out. When we come to ovarian cancer, and I think this is the one that you're alluding to, unfortunately, it gives such non-specific symptoms. So bloating, yes, poor appetite, can't finish the food. What the first signs that people talk about is the clothes size increasing in size. So the trousers can't do up, the skirt can't do up. So they're thinking, I'm just putting on weight.
Even though they can't finish their food.
Exactly. Yeah. Right, exactly. So again, these are sorts of things red flag to think about. Hold on, my appetite's not that great, but why am I putting on weight? Which is what a lot of women come and say, I thought I was just putting on a bit of weight, I've been inactive, etc. So all these sorts of things, unfortunately, they can be linked to bowel issues. So inflammatory bowel, irritable bowel. So you may find that the GP says, okay, try this medication for inflammatory bowel, try this medication for irritable bowel. So they're not wrong in saying so, or not necessarily fobbing you off. It's just, unfortunately, the signs of ovarian cancer can be it's non-specific. It can be quite non-specific. But again, change in bowel habit, bleeding, putting on weight, feeling generally tired, we, again, speak to your GP about.
talking about feeling generally tired, what does that even mean? Because
Yeah, I know.
when you go onto the
Yeah.
internet,
Yeah.
almost everything has got a
Yes.
symptoms, feeling generally tired.
Yes. No, exactly. And I mean, in this day and age where everyone is so busy, they're working, they have families, they have this, that, trying to juggle so many things, everyone's tired, right? Everyone is. I guess it's in combination with other things, or if you're starting to feel like, oh, this tiredness is out with what I'm actually doing every day. So maybe I am getting some rest and still I'm feeling very tired and feeling low in energy. No harm in just going to see the GP just to get things checked out, basically.
Okay. And if you've seen your GP and those symptoms are still getting worse, what do you then advise the person to do? Because, this regular going back to the GP and then bloods.
Yeah.
And then that brings me to the question as well. So why is it that even after people have had bloods, because some of these people, they've had blood tests, still then we're not able to pick those things up. So why is it so hard?
Yeah. So the first question, so if you keep having the symptoms, what do? Go back. Ask to see another GP. Say you're worried about cancer. Say the words. And in that triggers someone to say, okay, let me think. Because maybe even, again, it's not necessarily their fault. Maybe they're thinking along one route. And the moment you mention the cancer, it just makes them switch, and think, okay, no, let's go down this route. Let's investigate that. Let's refer them in. Ask for referrals to a gynecologist, referral into the rapid access clinic, these sorts of things. But still persist is what I would say. And if you're not getting through to one GP, you're right to ask to see another GP, go to a different practice, etc. Coming to the blood test again. So apart from cervix, there's no real screening test for ovarian cancer, all right, or for gynecological cancers. Even the blood test that we do, the blood test again is non-specific. So in some of them, yes, you do that particular blood test and it's called a CA125 test and it can be raised up in the thousands. And then, yes, that raises suspicion for the GP to then refer on or get a scan or something like that, right? Other times it's not that raised. And this can be raised in other things. So any infection, any inflammation, even just having a period, being pregnant can push this particular marker up. So it's very non-specific. And a lot of work has been done to try and see if we can combine this test with a scan and can we do predictive models, etc. for cancer. And unfortunately, it's shown that we can't. All right. So it's a difficult one, particularly with ovarian cancer. And this is why we know that a lot of people are diagnosed at a later stage because everything is very non-specific.
Is cancer a death sentence?
It's a good question. And I'm glad you addressed the stats at the beginning where it looked all a bit, it's a bit grim, it's a bit this. It depends. I think if cancers are caught early, then no. All right. People do tend to live a lot longer. We have a lot of a switch from, diagnosis of cancer to death to now living with cancer. So there are a lot of people you'll find that are just chronically have stable cancer. And there is such a thing as having had stable cancer, been on chemotherapy long-term, a tablet a day, for example, and that keeps their cancer at bay. So no, the cancer's not going away. Yeah. It may eventually, yes, at some point may progress.
Things like prostate, for example.
Exactly. That's another really good one. Exactly. That people, often die with it, but of something else. And it's just there, but it's just stable. So you find a lot of people are living with cancer, but it's not automatically a death sentence these days.
So why is it so difficult and challenging to treat it like any other illnesses or diseases? I know there are other ones out there like HIV and all of those stuff that is difficult to treat because they are viral. Why is cancer particularly difficult to treat?
I think because there's so many different types. And I'm not just talking about types in terms of where exactly in the body, but even in one particular body part. For example, if I take ovary cancer, there are so many different cells that it can arise from, that different treatments are needed to treat it. And of course, we as medical professionals in the medical field rely on funding of research to be able to say, okay, this is the cancer you've got, this is the treatment you need, rather than just blanket treating all cancers with chemotherapy, for example. So it just needs funding, it needs research, it needs time to actually look into things.
Okay, so can you talk us through some of this? Because you mentioned chemo, immunotherapy, and all of those stuff. And I know you are more surgical. So when those guys have done theirs and they said, oh, this person needs surgery.
Yeah.
And how did I get to know? I started watching New Amsterdam
Right.
series. And to be honest, that was the first time I actually paid attention to oncology. Because, there are a lot of... But can you shed more light into what chemo entails and the other kind of treatment? What do they do?
Yeah.
And why is chemo so hard? And all of the controls around it in terms of you can't live with your family for some people because of the risk of infection. If you can just shed more light on that.
Yeah, sure. So as you say, yes, disclaimer, I am a surgical oncologist, and there are my colleagues who do the chemotherapy administered that would know far, far more than I do. But yeah, just to give a broad overview, the treatment of cancers can either be by surgery. So if it's early, you can remove the cancer, then that's the best thing to do, really. And oftentimes, particularly for gynae cancers, it's in combination with chemotherapy. So we often do the surgery and then we do chemotherapy afterwards.
And why do you do chemo afterwards?
So if there are any tiny little cells that we couldn't see at the time of surgery that may have started to spread, then it's a good idea to have chemotherapy, almost like preventative. It's not necessarily preventative, but of a way of just, any tiny cells just to get rid of and reduce the chances of a cancer coming back, basically. So then we tend to give it in the combination. So we do that a lot with ovarian cancers in particular. So there's surgery, there's chemotherapy, there's radiotherapy. Within the chemotherapy now, so traditional chemotherapy is usually one drug, combination of drugs, which go through the vein. So the patients will come in, they'll have in the chemotherapy suite, they'll have their bag of chemotherapy drug, and then they may have to, different regimes are different. Sometimes are a couple of times a week, some are, every few weeks, and each cycle of chemotherapy is a month, basically. So they'll come in, they'll have their chemotherapy as a day case type of outpatient type procedure, and that's the drip running through the arm. Now, what chemotherapy does, the idea is that, as I mentioned, with cancer cells, it's dividing very rapidly. And our bodies, or each cell within our body, has its own regulation system as to whether it divides, whether it grows, whether it undergoes death, exactly, or not. So the idea behind chemotherapy is trying to push it into the death cycle, so it kills the cells, essentially. All right. So that's the idea behind chemotherapy. Now, unfortunately, there are a lot of side effects of that because, of course, if it's going to kill your rapidly dividing cells, it can, of course, kill some of your normal cells. And things like the hair loss that you get is because the hair follicles are growing. Of course, if it's going to affect the hair thins and eventually falls off. So those sorts of things. The blood cells, so what takes a big hit is your white blood cells, so the cells that fight infection. So again, they start to reduce the bone marrow that produces all the cells, etc., that fights infection. That dampens down. That this reduces their ability to produce like white cells, etc., etc. And that's where you get that you have to be very careful if people are in that phase where the white cells and everything are a bit low. Then they're more prone to developing infections, or if they do catch infections, it take a bit longer to fight it off, basically. So it becomes more serious. So that's why they have to be very careful. And particularly around the time of COVID, for example, people, at one point they were even stopping chemotherapy because of that risk of dampening the immune system so much, and then having this patient develop COVID, for example. So these are the things that need to be considered. It has other effects. You get numbness, tingling in the finger, in the feet as well. And it's just the way, unfortunately, one of the side effects because of the nature of how chemotherapy works.
Wow. Oh, interesting. So when some people, and they hear this, they've been treated and they've been declared free of cancer, and then they've gone to live a normal life, they've changed their diet, all of those stuff, and then it comes back. What are the leading causes from maybe research or from your specialization that leads to cancer coming back?
Yeah. It's a tricky one. Oftentimes it's just the nature of the type of tumor there is. So you have to think the fact that so there's two ways to answer that. Could be genetics. So maybe they've got a genetic predisposition. You've treated that first cancer. Unfortunately, the genetic predisposition predisposition is still there. So unfortunately, it means it comes back later on down the line.
Except if you mutate all your cells.
Except if you mutate all your cells, exactly. The other thing is those that develop sporadically. Now, whatever, even though they've changed their diet, their lifestyle, stop smoking, etc., there's potentially some inherent something within the body, which means that their cells have a more tendency to undergo a mutation and then cause a cancer. So yes, they've had the first cancer, and I've actually seen patients who've had cancers, different parts of the body, and each one treated and absolutely fine. You know, someone's had breast, kidney, she's had ovarian, she's had this, she's had that, you know,
and they still survive,
and they're still here. They're still here. So they're, you know, the cells, there's something about the cells in the body.
Ask them to play lottery.
I know, right? Exactly. So I think that's the kind of the best. And there are some cell types that unfortunately they are just aggressive types. So even though you treat it now, it will come back later down the line. But the idea behind treatment is that you give them that time, you prolong the time from it coming back, basically. So you give them time to live their life, give them time to, you know, spend time with family, meet or, you know, see weddings, you know, births, all these sorts of things. Exactly. Do their bucket list, etc. So some, we do know it will come back, but the treatment is just prolonging that time for it to come back.
How do you go about telling a patient that they've got cancer? How do you go about doing that? Because that's tough, isn't it?
It is tough. So as I said, where I work, actually a lot of the referrals they're already told at their referring centre. So a lot of that's done before they even come and see us. So they know, and they're well versed, they know the results. It's just about talking through the next steps. However, for example, in my rapid access clinic, where they were referred into the GP with symptoms, and I may do a scan and I see some, you know, I scan the ovaries and it looks like it's cancer, or I scan the womb and it looks like it's cancer. Those are the difficult conversations to have. Now, we're very good in terms of cancer services altogether in the UK, in that we have clinical nurse specialists or Miller nurse specialists. So often what I will do is try and get them in at the same time, and already that's showing the patient, oh, something's not quite right here, if you see what I mean. You as yourself, you sit in, someone scanned you, they go a bit quiet, and then they're calling someone else to come in, you know. So already that's kind of almost setting the scene, like, okay, you know. So I often see them with the nurse specialist. Obviously, if they've got relatives with them, the relative comes in, may check that they're happy that for the relative to be there. And then I just kind of slightly, you know, start to slowly break through. Look, I've done this scan. You know, your GP referred you because of these symptoms. They were worried potentially about cancer. I've done this scan. I've seen some masses on the ovary. It doesn't look normal. I'm going to need to do some further investigations. I'm going to speak to you in 2 weeks' time when you've had the rest of the scans. So usually we refer them on to more detailed scans like CTs, MRIs. I will speak to you again after that. My nurse specialist will also speak to you. And then, you know, you just make sure that they've got contact numbers for the nurse specialist, contact numbers to be able to talk to you. If there are any questions that once they go home they forget they want to ask, just be available to be able to do that.
Thank you. I'm going to ask this question now, and it's about what Mel Gibson said. So he claimed that he had 4 friends that were diagnosed with cancer, and they used 2 medications, which I'm not going to mention because we don't want to spread false information. And he said they were healed. I think he did that on Joe Rogan's podcast. And they were saying, so why is it that they're not prescribing those medications to people, even though they know they would treat the ailment? And they said on that podcast that is because the pharmaceutical companies wants to make money, so they will never give you a cure so that people can keep coming back, which is stuff to say, because why would somebody wants to profit on the back of people dying? Exactly. So what do you say to this kind of claim?
Exactly. So I heard about this particular discussion, and the drug, again, we won't mention it, but the drug they're talking about is traditionally used as an anti-parasite type medications, and it seems that there's been some research study somewhere that it may potentially have some effects on cancer cells. Now, across the whole of medicine, we practice what we call evidence-based medicine, all right, which is essentially whatever new treatment, drug, surgery, whatever we're proposing that we want to give people has to go through stringent clinical trials, medical trials, etc. It starts off in the lab, then it may go on to animal models, and then we do trials in people, in humans, and then, you know, if it's gone through all the checks and everything, then we release it and say, oh, it can be used for wider people. Now, as far as I know, these medications that have been described haven't gone through that in the cancer setting.
So it's not like it's not working. It's not like it's working. It's just that it's not gone through those stages of testing.
Exactly. So having a look at some of the, you know, even the papers that suggested it, they have themselves said it still needs a lot more work, you know, to see is this something that can be used. Again, it's the different types of cancers. It's the different cancer groups. Where exactly is it even affected? Like I say, even within gynecology, with the 5 different cancer types, there are hundreds of different treatments for each different one, and one doesn't necessarily work for the other. So to say that this particular medication will treat all of cancer, exactly, is really, you know, we have to be careful about it. Now, like I said, I'm not saying it may not have its use. A lot of the medications we use came from the back of using it for something else, and then someone realizing that, oh, that side effect actually treats XYZ. So it's not saying it may not have use, but it's saying it needs to go through the stringent processes first. And then, of course, yes, we have to talk about the finance aspect of things. It's private versus, you know, for us, NHS, okay? And a lot of these medications will be quite expensive to use. And it's about making sure that the funding, the resources, etc., are available, are there. If it's this so-called wonder drug that it should be, should the funding go into it, then absolutely fine. If not, if there's other things that are better, less side effects, because of course we need to look at the side effects of these medications. You know, there's different people are made up differently, different bodies. They may have the same tumor type, but they're going to react to medications in a different way. So, you know, all these things need to be considered first before we say. But
for people that have been told they got terminal cancer, I don't think they're concerned about side effects at this stage.
Very true, very true. But then again, it's about knowing what the effects are so that you can properly counsel somebody and say, okay, you may not care about the side effects, but okay, what if the side effect is something to do with the heart and actually gives you chest pain every day, even though you know you've got terminal or a headache every day, you know? What if that's the side effect? Maybe you turn around and say, actually, leave me with my terminal cancer, you know? So we still need to research it enough to properly inform a patient to say, like, yes, okay, it may work, but these are the side effects. Are you happy with these side effects? You know, to be, if you are, fine. If not, you know, we need to have that full information that we can tell patients.
Still on treatment and different kind of treatments that people have been brandishing out there. There was a particular program I saw on TV as well, where some individual have claimed that mindset with certain diets. So they actually went into this rehabilitation home, they called it, and the guy fed them on a particular diet with a lot of yoga and exercise and stuff like that. And they said, and he claimed, the owner of the rehab center claimed, he's got about 90-something% success rate in beating cancer to remission. It's almost like when you stab yourself, you stab the cells as well. What do you say to this?
Yeah. So again, these are my views. I'm not speaking for the whole of NHS doctors or anything at all, okay? I personally think there is a role for holistic treatment and management with cancers. I personally do feel that. So I'd never say, no, don't do yoga, no, this is a fad, this is this. However, what I would say is this should be in combination with the you know, the treatments that are already out there. It may be that it helps you to manage the side effects of chemotherapy better. It may be that, you know, my patients, exactly, again, I do surgery, and a lot of the time I say to my patients, you know, make sure you're exercising, you're not smoking, you go and do this, go for a swim, etc. before the surgery. So you've got your body in such a state that when you come through the surgery, you know, it reacts, you recover very well. Again, high protein diet, which is good for repair. I often tell my patients to have as well before and after, so it helps to repair and regenerate, etc. So I'm not against these kind of, you know, holistic views on treating cancers, but to say on its own, and again, we have to bring in the evidence-based medicine. If there's evidence that there, you know, so many people have been treated by this, then of course we can look into it. But as far as I know, there's not the real hard evidence out there to say just this alone will cure your cancer. So I would just take it, very carefully.
And that brings me to counseling.
Mm-hmm.
So, because a lot of, we're talking about mental health and resilience these days. And when somebody's been given the diagnosis that they've got a terminal illness, i.e. cancer, if their state of mind is not in the right place, can that accelerate the illness?
Definitely. Again, I'm not talking based on evidence or anything like that studies. There probably may have been some studies out there. Certainly from what I see in my practice, from what we call anecdotal evidence, I definitely see that. I see the patients that do better are the ones that already are coming in it saying like, no, this is not going to get me down. I'm an active person. This is just a small part of my life. Once I've had my treatment, I'm going back to being active, and I'm not going to let this get me down. We find that they do much better compared to someone who, maybe already struggling with mental illness and then has this diagnosis on top of it and just doesn't have that fight. And you can see when they come in, they just don't have the fight to get through the whole process. And I do see that. And I think hence why I say the holistic aspects of managing and treating cancers is also very important, but in addition to what the clinical team are suggesting as well. Before
I ask if there are any new treatments, pioneering treatments out there, there is something that really baffled me, and it was transplant.
Okay.
So, and the journal came out not long ago. It said the first case of spread of cancer through transplant of ourselves. This person has got, you read that as well. They've got a new liver.
Yes.
And the person they got, the donor, had died of lung cancer. But their autopsy did not detect the cancerous cells in their lungs until this person already received the liver.
Right.
So a week later, when they did the autopsy and found cancer in their lungs of the person, of the donor, they then took the liver out of the person they already donated it to and gave them a new liver.
Right.
But then they still died of cancer.
Right. That's an interesting one.
Yeah.
It's an interesting one. I mean, I would have to look into it properly. But is there we know that cancer spread through blood vessels, lymphatics, etc., etc. So is it that there was something that was there that is now kind of spread in through the blood vessels? I guess in theory that can happen, but I would have to look specifically at that to really know that. Like I said,
what baffled me was the fact that I know they carry out rigorous tests
exactly
before they give these organs.
Exactly.
And it's still part of that testing a week later that they then did to then found out that the donor had cancerous cell.
Yeah.
And they took the liver out.
Yeah.
But it was just too late. Just a week.
Yes.
And they died of the same type of cancer because they tested both of them.
That is the same tumor. It's an interesting one, but there's so much to unpack there. I don't know if there's been other reports of that. That's another thing that needs to be looked into. I think
that was the first confirmed report of it.
So reports of that. Is it coincidence that person has the same cancer?
No.
I'm just saying.
Basically, why they actually published it is because they've ruled out coincidence.
Right,
because the person that was given the liver didn't have any cancerous cell
when they did all the checks and everything.
When they did all the checks. Sure. It was after, and this tumors will have a signature.
Yes.
I think they had the same signature.
Right.
In the test.
It's an interesting case. It's
very interesting. I had to read it. I was like, wow. What was the hope? What I just say is our body is very sensitive.
Yes.
And I think this is why I encourage people to live life in a decent way, but live life in the way you're not going to regret it.
Exactly.
Just live your life in the way you're not going to regret it. Thank you very much for that. What are there any new treatment that is being trialed? I heard recently of targeted therapy.
Yes.
Do you want to shed more light on that?
Sure. So again, this comes under the remit of the medical oncologist. So remember I had spoken about genetic testing on certain types of cancers. So what we can do now is actually test, once patients have had surgery, for example, or they've had a biopsy, we can now test the tumor itself as to whether it has any genes that are lacking or genes that are mutated, etc., as well as testing the patient's blood to see the same thing. And now treatment, what they mean by targeted treatments is that the treatment is now looking at, based on this gene mutation, based on the tumor mutation, what treatment can be given to that particular patient based on these two things. So that's what targeted therapy may be. And targeted therapy can be in the form of immunotherapy, for example. And this is about how your immune cells then attack help in the treatment of these cancers or attacking these cancers and getting rid of these cancers. We have medications that block the blood vessels or the blood growth to the cancer, for example. So yes, there are a lot more in the medical oncology kind of world and field where they're looking at the actual tissue type, the tumor type, and developing or certainly giving medications based on that particular tumor for that patient. So that's what essentially, very broadly, what targeted therapy is.
Oh, this has been very insightful. And thank you very much for all of that insight. We've unpacked a lot.
Yes.
In here. What's next for you? Because you rotated everywhere.
Yes.
Are you just going to do this for the rest of your medical practice, or where do you see yourself in the next 10 years? It's not an interview.
I should prepared my answer. No. So I've been a consultant now 2.5 years, I think it is, where I'm working at this tertiary unit. And of course, I'm starting to just, establish myself, develop certain things within our department. Just to help to, develop, streamline the care of our patients, essentially. I've also started to do a little bit of private work myself, so I'm doing that also. But I have a very... what I would really like to do is kind of give back in the same way that you're thinking of giving back, but abroad. So my family are from the Caribbean, for example, and I am quite keen to see how I can kind of use my skills, my knowledge, etc., to go to places like the Caribbean, and kind of share those skills, share that knowledge, and help to develop these types of areas than where, something that over here would be like, oh, that's standard for us. What do you mean over there? They may be struggling to achieve and to help and, reduce their kind of numbers. Similarly, I have a colleague who does missions in Ghana, for example, and she had invited me across. It just so happens the timing doesn't work, but next year I hope to do that. So I would like to be involved in kind of the global healthcare and the global tackling globally the cancer issues, because of course we're talking about the rates, but these are kind of UK based rates. They're very different across different countries because of resources that they have or under resource that they have, or sometimes, like I say, the lack of the knowledge or the skills, etc. So if I can just go and do some training or something that will help out, that's where I kind of see myself moving to.
This question is a little bit personal, and you don't have to answer it if you don't.
Okay.
How do you feel fulfilled? And I know your drive might not be the financial reward, but when you look at how much people with your knowledge and specialization are paid, how much they're paid under NHS compared to what they're paid in the US, Canada, Australia. And to give it an insight into this, of late, not oncology, but cardiologist, I was just reading something online and it just picked me like, okay, let me even check the disparity in pay. And in the UK, I think, without locum, I think it's about 90 to 130,000 pounds basic. In US, I know it's private, but it's about $350,000 to $550,000.
Yes.
In Canada, it's about $350,000 to $450,000.
Yes.
Canadian dollars, and in Australia, it's about $250,000 to $400,000 Australian dollars.
Yes. Yeah.
How do you reconcile this when you know you could earn way more if
Yeah.
you leave the shores of this country.
Yeah. I think, like you say, I guess it's the structure as well. So it's the structure of the systems where we're very much NHS based. It's, you know, the funding and whatever that's available there versus private based. I think a lot of us accept that within the NHS, this is the remuneration that we will get, and therefore a lot of people will go off to do private work if they feel they need that extra, or, you know, whatever their reasons are for doing that. My understanding, if you look at, although Canada might be different, but if you look at the States and all these places, they work incredibly hard.
But if you're going to keep your money,
Very
you don't
true.
mind hard work, would
Yeah,
you?
yeah, that's true. But then, do you get time to actually enjoy it?
I'm sure
This
they
is the
do.
thing. You're saying.
You know, when you look at the big houses and the big cars,
Yeah.
you look at the quality of life as well.
Yes.
You know, because I come from originally from Nigeria, which is mainly capitalist as well.
Yeah.
If you don't work, there's no benefit.
Sure.
So you are incentivized to work hard.
Yeah.
And you look forward to your 10 days holiday, because we don't get 25 days like in the UK. You get about 10 days. You can go anywhere in the world.
Yeah.
Enjoy yourself. Come back. But when you come back, you're still coming back to big houses, big cars that are worth the effort you're putting in, which is the same thing they're getting over there. So even though it might not be the 25 days holiday, but even sometimes when you go home, you know, it's massive space.
Yeah.
So are you thinking of jumping ship anytime soon?
I like my 25 days holidays. I can't lie. I love traveling. So for me, 10 would just be disastrous. No, it's I mean, I guess it's what you, if that's what, you know, you enjoy or sort of think from life of coming back, you have your big house, you have your this, your that. Like I said, we are preferred the time to actually, you know, go off to enjoy, to relax, to, you know, rather than saying, oh, I've come back to a nice big house, which of course is great. Everyone aspires to that. All right. But I guess there are other ways or other, you know, if you wanted to do that in the UK, then maybe medicine would not be the route, or
if medicine is not the route, where then is the route?
I hear what you're saying. If we're, you know, we're in these kind of jobs and it's like, how can we not be paid to these sorts of levels? I hear it. I do hear it. Unfortunately, it's the way it is.
That's what we are. Okay. Now, what I promise you guys, I'm going to bring an economist into the studio, and then we're going to talk about why the UK is where we are at the minute.
Yeah.
But thank you very much, Doc, for coming to the studio. Any last word for our viewers or listeners?
Yeah, just to, for me, I really want to hone and push the screening. Please go for your screening. We have screening programs for breast, for cervix, prostate. Please go for screening when invited, for bowel as well. People often have this thing of, you know, I'm healthy, I'm well, why would I go for these things for you to try and find cancer? It's not always that. A majority of people, I mean, speaking for cervical cancers, for example, the majority, over 80% of women who come for screening will not have a cancer, right? So it is just saying, look, quick test, this is it, you're fine, off you go for the next 3 years, 5 years, whatever it tends to be. So my advice is, please go for the screening. It's not about people trying to find cancer, but if there happens to be something, it can be picked up early and it can be treated.
Good. Thank you very much.
All right.
It's been a pleasure having you in the studio, and I'm sure everyone is benefited from yourself.
Thank you.
And I wish you all the best in giving back to the community. And if you decide to go to the Caribbean, or you go to Ghana, or you should go to Nigeria before Ghana. But if you decide to go, I wish you all the very best. And thank you.
Thank you so much. Thank you for having me.
Cheers.
Thank you.